recording at the end of the things, right? So this is medical MCQ for all. It's a company, right? We are providing the study material for all Gulf Prometric exams very quickly. Those who are new in the platform, we provide 1000 MCQ book, and also the recently the book and ebook is in January 24 we updated. So those who wants they can order it. Online subscriptions and coaching, the coaching same way what I'm doing. I'm taking every Sunday free mock test, right? So I recommend you, those who are not in coaching, at least attend the right the things. It is absolutely free and it is worth. I mean, earlier we used to charge 50 US dollar, right? So now you are getting absolutely free. So understand the importance of this. So don't miss and share link with those who are aspirant for DHA, HAD, MOH or other. We would be happy to join each and everybody so they get at least the idea how to prepare, what to prepare. We have WhatsApp subscriptions as well. We have Oman coaching, Viva as well, Oman Viva coaching and online subscriptions. We have all the data flow services as well. Dr. Anjali, who is based at Dubai, so you can contact her. Her number is there. And we have one excellent short package as well, which is money back guarantee. If some candidate don't pass the exam, will refund. That's it. So this is what the thing is. And mobile application on Android as well as iPhone. So don't miss to download the mobile application. Those who still not downloaded the mobile application, you download it. Excellent. You can completely surf all the website through the mobile application and it is extremely user friendly. This is myself, Dr. Munjal Pandya. I am clinical practicing fellow for more than 20 years. My main core area of interest and area of this practice is more than 15 years. I am in exclusive blood disease, that is hematology and medical oncology. So hopefully this would be one of the great lecture from my side even because this is my main subjects. So I am dealing with all these things for more than 15, close to 20 years, and I have more than 10 years of teaching experience and treated more than 100,000 hemato and oncology patients so far in last 20 years. So hopefully you will enjoy. This is Dr. Aarti, who is a consultant pediatrician. So she is taking all the pediatric lectures. She is also gold medalist and she is a brilliant lady, right, delivering the excellent lectures on every day, turn wise. This is Dr. Maddie. She is again internal medicine based at Oman now in Sohar. So she is also a main guide for Oman coach and all. Oman Viva, sorry. So this is all our team. Dr. Shikha Garg is a consultant gynecologist. The good news is that this lady from our team is shifting to Dubai. She also cracked the DHA OBGY. She got good placement in Dubai. So she will be probably available for further guidance in Dubai. So she is right now taking all the lectures for us for gynecology and she will continue as well. And we're going to start shortly exclusive gynecology things once she settled down next month there. Dr. Ankit, for your knowledge, is a gastroenterology, is a DMCH, right? So he's a not specialist, he's a super specialist. So he did MBBS, he did MS, MD, and then he did DM, right, in gastroenterology. So he's practicing in my city only. So he's a brilliant guy. So and along with that, we have a lot of team. The Pallavi, I think a lot of people knows Pallavi. So Pallavi, this is Pallavi. Meghna is also into the data flow. Right now, she is in UK, but she will soon back in Dubai. She is there in Dubai for last 3 4 years, so you can contact her as well. And this is Pallavi, our support manager, IT team. This Sagar. So that's it. We'll switch mainly. This is our book. We recently published 1000 MCQ book with answers and explanation. So if you wish, you can order it online. And this is once in a lifetime, this now or never offer. Earlier, our coaching was like around 500 USD. And now it's 250 only. So almost flat 50% discount. So those who wish to join the regular coaching, they can join, right? They can join. So this is the best opportunity. And this is what I told the data flow, Dr. Anjali Sawant. She is also based at Dubai. She is now in India, but she will be reaching on Tuesday. So if anybody wants the number, this is all the numbers. I will again share or drop me message. It is there on the this thing, so you can contact her for any data flow services. That's also we'll go to the mainstream now. Just be more active, concentrated on the things, right? I want you to assess yourself. I don't want to ask each and everybody what's your score, but this is like exam, right? Every Sunday we are doing for last 6 months regularly without failure. So try to assess yourself that how much you know, what else you want to know, what is the more high yield points there. So let's jump to the first questions. Philadelphia chromosome refers. Four options: long arm of chromosome 9 and long arm of chromosome 22, short arm of chromosome 9 and short arm of chromosome 22, short arm of chromosome 9 and long arm of 22, and long arm of 9 and short arm of chromosome 2. So first answer we'll discuss. I wish everybody post their answer. Either they can interact with me or they can put it in the chat box. Yes, this is a case of CML basically. This is case of CML. Yes, Dr. Ajudani, let's start the discussion now, real discussion. So, Dr. Ajudani, now tell me what this case is. Those who are new attending the first time, again, I will give you excellent triad, especially for new people. This is triad of MCQ, triad of MCQ. Whenever you are you are solving any MCQ, you must know in one MCQ, you must know at least three answers. What three answer? What is the diagnosis of this patient? How you investigate this patient? And after this, both the things, how you treat this patient. So if you develop the art of answering these three questions in a one questions, means if you are say for example, solving 100 MCQ a day, means you are solving 300 MCQ a day, because along with this you are doing this and this also. So try to make a practice from today. I don't want you to read for 6 hours, 8 hours, 10 hours, 12 hours. It's all hard work. Don't do the hard work, do the smart work. Whatever you do your best. You try to understand the subject, you try to understand the logic, right? And it is absolutely not a difficult exam, believe me. I can guarantee you, if somebody wants the 100% money back, come to me. I will challenge and guarantee, written guarantee, that you will pass. So believe in yourself. Try to be more sincere. Forget about all social media while you are studying. Leave it, it's all useless social media. Try to concentrate on your life and future. So do properly the things. Yes, Ajidani, now tell me.
Yes, sir.
Yes. So your
It's
answer is
a
C.
yes, sir. It's a case of CML.
Okay, so diagnosis, sir, will go slowly one by one, right? We are not in hurry. We want to understand the things rather than mug up the things. So diagnosis is CML basically, because Philadelphia chromosome is seen in CML. Okay, fine. So now in CML, there is a translocation of 9 and 22, right? And that is called
Yes,
as
sir.
a PH chromosome or Philadelphia chromosome positive, right? So this
Mm.
Philadelphia chromosome, so let me draw the chromosome picture. This is one long arm. Just for your knowledge, I mean, we probably forget that was in the medicine days. So this is a, in general, chromosome. There are 23 pairs of chromosome, means number is total 46, right?
Yes,
23
yes, yes,
pairs
sir.
of chromosome, 23 pair of chromosome. So what is that? When you have chromosome here, if you have a cytogenetic 1, 2, 3, 4, 5, 6, blah, blah. So in 9 and 22 chromosome, there is a translocation, means some part of 9 chromosome going to 22 and some part of 22 chromosome going to 9. That is called translocation, transfusion, transplant, taking from one, giving to other. Transfusion, you draw the blood and you give to other. Transplant, you take the kidney from one, giving to other. Trans means exchange, right? So
Yes, sir.
translocation, so location, translocation, no need to mug up. So location of 9 going to 22, 22 location, some going to 9. And this, the mutated chromosome is called as a Philadelphia chromosome. So they are asking, right, long arm or short arm. So this is short arm, right? So what is what? So correct answer, it's little tricky question, but it's important. Long arm of 9 and long arm of 22. So this is a long arm, this is called short arm. So some part of 9 chromosome from long arm and some part of 22 chromosome from short, long arm of 22 and long arm of 9, they translocate and create a one chromosome, and that is called as a Philadelphia chromosome. This is excellent picture for better understanding. So concentrate. If you don't understand, I would be glad. I will last this lecture for 3 hours, 4 hours, don't worry, but ask the question, right? So this is a 9 number chromosome, right? So this is, see, this is a 9 numbers of chromosome, right? So this is normal, right? This is normal 9 number. CH9 is 9 number. CH22 is a this chromosome number 22. So what happens, right? This is short arm. So this is inside short. This is inside long. So that is why long arm of what chromosome 9? The one portion of 9 is ABL. And here again, this is a short arm. This is a long arm. Is that clear? Yes or no? Ajdani, is it clear? Yes or no?
Yes, sir.
Right?
Yes,
so
sir. Yes, sir.
So both long arm of 22, long arm of 9, there is a translocation. One portion of 9 ABL going to 22 and this BCR is going this. So what happens? This is the Philadelphia chromosome, right? This Philadelphia chromosome, there is a BCR component and ABL component, and this is called as the oncogene, oncogene, and this gene is responsible for multiplication of WBC, and that is why you have high number of WBC in CML. This is kind of switch, I can say switch to teach my resident. I tell that there is a natural switch God has given, right? When the WBC is producing, there is one switch. This switch regulates the WBC production, but because of this mutation, now this switch is not working well, and because of that WBCR keep multiplying, so they present with the leukocytosis. Sorry, right? Is that clear so far?
Yes, sir.
Right, so this is called the PH chromosome, Philadelphia chromosome. So this is what the Philadelphia chromosome. So what was the question, right? Long arm, short arm. So there are combination, long short, right? 4 combination. So among 4 combination, you just need to simply remember 9 number and 22 numbers, long arm chromosome. There is a translocation. The gene develop is a BCR-able, and this BCR-able is responsible for the pathogenesis of the CML. Second questions. Now let's move to lots of question, not second question, lots of question. So Ajdani, you finish this chapter because you started this. So I want to answer you everything, right? It's a good opportunity for you to answer all the things you will learn, and your CML is clear today. So what's the diagnosis? What's the diagnosis here?
CML.
Wonderful,
CML.
CML. Wonderful. So this is the first question, diagnosis. Anybody is open to ask me any questions. Don't hesitate, right? If you are not speaking, means I thought you understood everything well, but interrupt me, I would be happy to answer. CML, BCR, ABL seen in which other condition? Ajdani. So one is CML. You can see the CML BCR able gene. Is there any condition in the body where you can see the BCR able? Yes or no? Or you don't know?
Yes, sir. Yes, sir.
What are
I
the
think
conditions?
ALL.
AML, sir.
Not AML, ALL. Somebody told ALL. So that's the correct answer. So acute lymphoblastic leukemia, they have PS positive chromosome, means Philadelphia chromosome. CML is also Philadelphia. BCR, ABL, again for your knowledge, may not important. There is a one tumor in the body called as a GIST. Have you heard of GIST? Gastrointestinal stromal tumor. So this is called GIST, right? Gastrointestinal stromal tumor, where we do sometimes this genetic study, and we also found the PH chromosome positive as well. So GIST, again we are giving 3 years course of imatinib, at least imatinib, right? So this is how this is said. So we answered 2 questions so far. Diagnosis is CML, BCR able seen in which other conditions? So these are the other condition where we supposed to see the Philadelphia chromosome. You must know which drug blocks the BCR oncogene, Ajdani. Which drug? There is a one drug which blocks this BCR able gene and stop the overproduction of WBC and stop the progression of CML. Excellent. Imatinib.
Yes.
So this is imatinib. Another drug is a dasatinib. Third drug is a nilotinib. Fourth drug is a bosutinib. and there are lots of drugs comes in the market. So if you are more interested in CML, it's my favorite subject. We'll discuss, because otherwise CML 2 hours will go on in CML only. So this is just the exam point of view I'm telling. So imatinib is the main name you must remember. What exactly the imatinib do? Let me tell you. Imatinib block this oncogene BCR-ABL. Imatinib will block the BCR-ABL. So what exactly the drug acts here? BCR-ABL. It blocks the BCR-ABL. So there is a stop the progression of WBC in peripheral smear. Is that clear? So this is the targeted therapy. Have you heard of the targeted therapy? Yes or no? Have you ever heard there is a targeted therapy in oncology? So this is absolutely a targeted therapy.
Yes.
Why
Yes,
it is
it's a
targeted therapy?
different
Because
treatment.
it targets the BCR-ABL. It directly acts on the BCR-ABL. So it will not act on any cell which does not have BCR-ABL. So it exactly hits and target the BCR-ABL. So this is a new completely the door open in a medical oncology is a targeted therapy, and next to the targeted therapy is a immunotherapy. So I will do some time in oncology lecture, but just right now I'm concentrating on the MCQs today. So 2 questions, 3 questions we answered so far, right? Now fourth question, Ajdani, what do you think? All right, 3 questions we answered. It is a CML, right? BCR-ABL seen in this condition. This is drug of choice. How many percentage of patient has a BCR-ABL positive in CML? How many percentage of patient have BCR-ABL positive in CML? So if you have 100 patient of CML, how many positive BCR-ABL and how many positive
10%.
PH? Sorry,
10%, because I know
25%.
90% is positive and 22
great.
22 chromosome translocation.
Great.
Otherwise, positive.
Fine. So just for your knowledge, PH chromosome positive means what? Translocation 922, as I told you, that is present in 90% of the patient, 90. It's important thing. That is why you need to understand. And BCR-ABL is present almost in 98% of the patient. So I am seeing the patient in my OPD that I'm suspecting completely CML, but when I do the bone marrow biopsy and I send for the cytogenetic, Philadelphia chromosome is negative. Why negative? Because 90% positive means what? There are 10% of the patient who have Philadelphia chromosome negative. So what to do? How to confirm? Then I do the BCR-ABL in plasma. And this BCR-ABL is positive, and then I confirm the diagnosis of CML. Is that clear? Yes or no? If you don't understand, tell me no. Everybody, yes or no? We are more than 40
Yes,
people,
sir. Yes.
right? Wonderful. So I consider that you know the things. How many phases of CML? How many phases of CML? Anyone knows? Anyone knows? Anyone
Phases
knows?
are there.
How much, doctor?
Three phases.
Yes, 3 phases. So can you elaborate little bit what? Let her speak one by one. So 3 phases, doctor, right? What's your name?
Harsha.
Harsha. Yeah, great, wonderful. So can you tell me which are the 3 phases, Dr. Harsha?
And the first phase is chronic.
First phase is chronic phase of CML. Great. Then?
Second is accelerated.
Wonderful, wonderful. Accelerated. And third?
Third is blast crisis.
Wonderful. You got 100 out of 100. Very happy. So these are the 3 phases of CML. So what happens? Let me tell you one example. This is statistically, if I see 95% of the patient present in CML, 5%, 4 to 5% patient present in accelerated, and less than 1% fortunately present in blast crisis, right? What do you mean by chronic phase? Chronic phase, hemoglobin 12, this is hemoglobin. This is total count, WBC count and platelet. So hemoglobin 12, WBC count is 50,000 and platelet is 200,000. This is chronic phase. Just the WBC high, and usually there is a neutrophilic leukocytosis. What? Neutrophilic, important, because it's a myeloid series, not lymphoid series. Chronic myeloid leukemia, not lymphoid leukemia. So myeloid, sometimes I'll tell you stem cell related tree. So myeloid series is a neutrophil is a myeloid series, right? So neutrophilic leukocytosis, right? What happens when if you don't treat this with imatinib here in chronic phase, if you don't block the BCR ABL here, right? What happens? It will progress. Like if you don't treat diabetes in a 200 sugar, it will go to 300 sugar, it will go to 500 sugar, and it will go to diabetic ketoacidosis, coma, and he may die sometime. This is how it progress. So this is how the CML progress. Chronic myeloid leukemia, if you don't treat, it will go to the accelerated phase. What happens in accelerated? This 12 probably going 11, 50,000 becomes 70,000, and 200,000 becomes 150,000. And worst thing is a blast crisis. This will go to 8 hemoglobin, it will go to 100,000, and there is a absolutely 100% thrombocytopenia. So platelets are also low, and this is one of the worst condition. A chronic myeloid leukemia with blast crisis means it is treated as good as acute leukemia because there are blasts present, and if you see, hemoglobin will drop, platelet will drop, and WBC will rise. Why? Because the CML process is going high. So this is the CML, right? So this is, you must know little basic things because they are keep asking. Now they are getting little more tougher. I will share this slide, PowerPoint and video. So don't worry if you miss something. You can read completely and watch whole the video again, top to bottoms. Don't worry, but try to understand. And I would be more happy if you ask me the questions, right? So this is what the question number 5 we also covered here, right? So how many phases of CML? Excellently, very well done, huh, Dr. Harsha? So phases of CML: chronic phase, accelerated phase, and blast crisis. How to treat the blast crisis? Again, the same thing. Blast crisis again treated with the TKI, tyrosine kinase inhibitor, or imatinib, right? Imatinib. And if it not working, then you may go for the chemotherapy or as well, plus or minus. And I told you how many percentage of Philadelphia chromosome positive, 90%. Philadelphia chromosome positive, 98% as a BCR-ABL positive. Again, very important question I come across while I was reading. Which vitamin deficiency is commonly seen in CML? Anyone? Anyone? This is the exam question recently asked in DHA. I'll give you the options as well. Vitamin A, vitamin B, vitamin C, vitamin D, vitamin E. 5 options.
E, sir.
Wrong. Vitamin D. D for doctor. So vitamin D is the answer, right? So this is all the answer I posted here in the one slide, right? So just go and check it later on. I will share the PowerPoint as well as video as well. So let's move to the next questions very quickly. Vitamin B12 level in chronic myeloid leukemia is elevated, decrease, normal, or markedly decrease. Your time starts now. This all, don't take it lightly. This all question will you see in your paper. Believe me. At that time, you will remember me. I did a lot of research last week and try to gather, and hematology is a long topic, so we probably take 2-3 lectures. Yes, so answer, anyone? Open for all. Anyone? What happens to B12 in chronic myeloid leukemia?
Elevated.
Who is this? Please tell your name, doctor. Sorry, maybe we have 40-50 people, so I miss. Sorry?
Elevated.
Elevated. What's your name? Okay, just probably your mic is a bit slow. So anyone, any comment? Dr. Toprak?
Doctor, elevated.
Yes, elevated. Wonderful. So it is elevated. So answer is elevated. Excellent. Right? Why elevated? Any idea? Elevated, but why elevated? That is another second question. Sorry, doctor. Honestly speaking, your voice is low. Yes.
Normal blood cell production that leads to maybe because of like increased cell turnover.
Excellent. Brilliant. Sanjida. Wonderful. Very, very wonderful. Very wonderful. So this is increased turnover. More cells release the more turnover. So there is a B12 level is high in CML, right? So this is the first questions. You answered it. You nailed it perfectly. Second, manifestation of B12 and CBC and bone marrow. So can anyone tell me, this is all questions in exam. So B12 deficiency is there. What happens in CBC? What happens in peripheral smear? What happens in bone marrow? What happens to retic count? Anyone?
Yes.
One.
Sir, can I?
Yeah, anybody, doctor. Anybody.
B12, it is an macrocytic anemia which will increase the MCV and decrease the reticulocyte because reticulocyte is decreased due to RBC destroyed in the bone marrow.
Excellent. Excellent. You go ahead.
Yes. They might have increased LD in the CBC. We can see MCV will be increased and hematocrit will be decreased or normal.
So MCV is increased. Peripheral smear, what do you see in the peripheral smear?
Peripheral smear, we used to see macrocytes, hypersegmented neutrophil, hypersegmented neutrophil.
Hypersegmented neutrophil. And bone marrow hypocellular, hypercellular, or normocellular?
Bone marrow hypercellular.
You got 100.
Hypercellular bone marrow.
You get
Hypercellular bone marrow.
You get 100 out of 100. 100 out of 100. What's your name?
Dr. Preeti, sir.
Wonderful, wonderful. So I think you love B12 chapter, huh? Great, wonderful.
No, because of you said I read it.
Okay, wonderful. So one question is very well answered. I'll explain. Classical picture of B12, I'll explain. Another candidate, new candidate. Can anyone tell me what is difference in B12 and iron? Very frequently asked question in every exam. What is the major difference in B12 and iron deficiency anemia? So let me draw one line here, right? North Korea and South Korea line. Iron deficiency anemia, B12 deficiency anemia. Anyone, any volunteer, those who feel that I am good in this subject, means you, we can discuss.
The MCV will be decreased in IDE, iron deficiency anemia.
So let's start with the hemoglobin. So iron deficiency anemia, anemia means hemoglobin is low, obviously, right? B12
Yes,
deficiency
sir.
also hemoglobin would be low. So just by hemoglobin you cannot differentiate. Let's come to the peripheral smear. Peripheral smear, first of all, this is a normal RBC which is a biconcave. It's like a dumbbell, right? Have you heard of dumbbell shape, right? So this is a small RBC. Peripheral smear, it's a small RBC. This is normal size. Consider this is normal size. And here in peripheral smear, you see the large size. This is normal. Obviously, this is small. This is low. Small size. If the size of the RBC is small, we call it the microcytic. Micro means small. Cytic means size. No need to mug up. No need to ratify. Micro means small, right? Micro means small and macro means large. So microcytic, this is macrocytic, this is normocytic. No need to mug up. Normocytic, normal size, small size, large size, simple. So this is different. The difference. Are you okay, Dr. Preeti, with my explanation?
Yes, sir. Yes, sir.
Excellent. MCV normal, for your knowledge, MCV normal is 80 to 100. So here microcytic, small size. So obviously MCV is less than 80, and here B12 it is more than 100. And in between 80 to 100 is a normal, less than 80 microcytic, more than 100 macrocytic. This is 100% will come in exam because this is what they ask in different things. So whenever you see any MCV more than 100, never ever answer iron deficiency, because iron deficiency anemia, you never ever see the high MCV or macrocytic or more than. So when exam scenario say MC is 110, forget about iron deficiency. 110 means you think of B12, folate, other reasons we'll discuss anyway. So this is HB, this is peripheral smear, this is MCV, right? Retic count. Let's come to retic count. Because of iron deficiency, RBC is not forming, right? So retic is low here. Here the B12 retic is low here. So even retic count you cannot differentiate, right? Peripheral smear, excellent, I told you. Here microcytic, here macrocytic. And along with the macrocytic, as you rightly said, Dr. Preeti, there is a hypersegmented neutrophil. What do you mean by hypersegmented neutrophil? Let me draw the things. This is a one lobe, this is second lobe, this is third lobe, this is fourth lobe, this is fifth lobe of neutrophil. And neutrophil is a granulocytosis, so there must be some granule in the cytoplasm. That's it. This is neutrophil. What do you mean by hypersegmented? So anything more than 5 lobes, maybe 7 lobes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is hypersegmented neutrophil. It is none other than B12. across the globe, number one differential diagnosis of hypersegmented neutrophil is a B12. And if B12 is normal or not there, next immediate diagnosis is a myelodysplastic syndrome, where also you can see the hypersegmented neutrophil, Pelger UA abnormality, and there is a megakaryocytic hyper or hypolobated abnormality. So we'll discuss later on little bit in detail. But this is absolutely you must know. It's all high yield point I'm discussing, which is not in the book, any book. You will not get any difference in any book. If you find, send me. You will not find. This is all by experience we are telling you. To make it things bit easy, you don't need to mug up. So hemoglobin low, both the condition, retic count, both the condition low. Here the MCV low, here the MCV is high, right? And here peripheral small size, here large size, is microcytic, is macrocytic, and hypersegmented neutrophil is the things. In iron deficiency anemia, right? What happens to iron profile? Serum ferritin, serum iron, and serum TIBC. And fourth is a transferrin saturation. So when there is iron deficiency anemia, obviously iron is low. Store of the iron is a ferritin, so ferritin is low, iron is low, and because of nothing there, TIBC is high, total iron binding capacity. There are free radicals, free proteins moving the plasma. There is no iron. So they are absolutely free. They are high, and transferrin saturation is low. What is transferrin saturation? Serum iron divided by TIBC is a transferrin saturation. That's it. No need to mug up. Serum iron divided by TIBC is transferrin saturation. It is comes in the percentage, right? So anything less than 20% is a iron deficiency anemia. No need to mug up. Numbers are there in the exam. That's it. So what happens in iron deficiency anemia? This is a classical picture of the iron deficiency anemia. So they may ask you, 55 years male presented with this chronic anemia, iron is this, ferritin high, iron low, TIBC low. What is this anemia? They will give 4 options: iron deficiency, B12, anemia of chronic disease, thalassemia. No need to confuse. If you remember this, you can answer any question, any question. And in iron deficiency anemia, what happens to B12? B12 is normal. Simple. What happens in B12? B12 deficiency, B12 is low. Iron profile is normal. What do you mean by iron profile? Profile, any profile means there are a lot of things. Lipid profile, lot of things. Iron profile, lot of things. So serum iron, serum TIBC, ferritin, and transferrin, all normal in B12. Why? Because it's not iron deficiency, it's a B12 deficiency. So B12 is low. Here the iron is low, right? And B12 is normal. So that's all. This is the basic understanding of iron and B12. There are a lot more things to know, but for practical point of view, I am telling you. Any question? So far, any question? Yes or no? Wonderful.
Yes.
So again, the B12, let's get back to the question. So again, B12, right? So here the first answer is B12 is elevated in CML, right? Another manifestation of B12 in CBC we have seen, macrocytic, hypersegmented neutrophil, classical picture we have seen, iron versus B12 we have seen. And what are the stages of B12 deficiency? So if B12 deficiency happen to any patient, there are 4 stages, right? 4 stages. This is how they gradually go. Anyone knows? This is the most commonest deficiency across the globe, especially in vegans or vegetarians. So there is no, whether they ask or not, you go check your B12. I am guaranteed 5 out of 10 doctors, they have B12 deficiency. It's very common in India. Amongst the doctor, we did one research in my city. 70% of the doctors, 70% of doctors are B12 deficient, because they are using RO water. They are using lots of filters to filter the blood. So there is nothing, and they are all vegan. So B12 deficiency is very, very common. Yes, anyone? Toprak, you know?
So with the symptoms actually,
No, there is a classical this staging system, or 4 stages of B12 deficiency. So let me tell you, probably if you don't know. So whenever B12 deficiency develops, the normal level of B12, for your knowledge, 211, 200 and somewhere 50. This is the normal level. So what happens when 200 become a 200, 200 become 150, 1 become 100, and something become less than 50? So this is worst one, right? The lowest one, isn't it? Are you getting me? Yes or no? Tell me yes or no, right? So this is the thing. So first, the B12 level in blood will reduced. Second stage is B12 level in a cell will reduce, within the cell reduce. Third stage, development of neurological manifestation. And fourth is the development of hematological manifestation. And what's the hematological manifestation of B12? Low HB, megaloblastic anemia, high MCV, macrocytic anemia, right? Pancytopenia. This is all B12 manifestation or hematological manifestation of B12. What is neurological? Bilateral tingling and numbness, peripheral symmetrical neuropathy. Have you heard of this word or not? Yes or no? Right? Bilateral symmetrical peripheral neuropathy, most common. Then forgetfulness, lack of concentration, and sometimes they may develop the psychological symptoms as well. And these are the, as per the book, 4 stages of B12 deficiency. Stage 1, decrease the level of B12 in the blood, as I told you. Second is decrease the level of B12 in cell, within cell. Blood is different, cell is different. So within the cell. Third, neurological and psychological symptoms like anxiety, confusion, problem, balance, peripheral neuropathy, blah, blah. And macrocytic anemia, very large red blood cell, which you measured by MCV. MCV is a mean corpuscular volume, means average size of WRBC is simply known as a MCV. No need to mug up. Is that clear to everyone? Yes or no? Yes or no?
Yes, sir.
Yes.
Wonderful. At least interact with me, so I would be happy. So this is again, I posted a very nice slide for you guys. So this is the normal, right? Normal neutrophil. So if you can see, this is 1 lobe, probably 2 lobe, 3 lobe, 4 or max 5 lobes. And here you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, hyper segmented. Hyper segmented. Is that clear? Yes or no? Just to get a little better clarity,
Yes.
how it looks
Yes.
like under microscope. So this is hypersegmented.
Yes,
Less than 5 neutrophil or less than 5 lobes is a normal. Anything more than 5 is called as a hypersegmented neutrophil. That's all. So this is the end of lots of questions from my side. And earlier I told what deficiency vitamin with C, vitamin CML, which deficiency? So vitamin D, I told you already. Are we going well so far? So good?
Yes, sir.
Wonderful.
sir.
Enjoying. Wonderful. Agranulocytosis is defined as neutrophil count less than 100, less than 200, less than 300, less than 500. I want to calculate these things. I want to calculate. We are seeing full blood count or CBC. This report is #1 report irrespective of specialty, whether you are in gynec, emergency, neuro, surgery, medicine, pedia, ortho, psychiatry, you name the things. First investigation doctor right across the globe is CBC. You go and check the CBC. So you must know what is CBC, right? So I will tell you, you have one patient whose hemoglobin is 13 gram %. Total count or total WBC count is 2,000. Neutrophil is 10, lymphocyte is 80, EO5, BSO2, and mono3. How much is the ANC, means absolute neutrophil count? Please calculate all and tell me. I'll give you the 30 seconds. If you have any doubt, you can ask me. Otherwise, this is the scenario. You have one CBC, you have one neutrophil, you have to count the absolute neutrophil count. So how do you calculate? Those who are in hemato-oncology ward, this is the everyday's job. Every day they need to calculate ANC. Dr. Sanjida, do you know?
Not really, doctor.
Fair enough, no problem. So just concentrate how to calculate and what's the importance we'll discuss. Jomoli, any idea? Dr. Maha, do you have any idea? Dr. Maha Tawfiq, any idea, madam?
No, sir.
No problem. So have you heard of this ANC, or so far you did not heard of ANC? Dr. Neelam.
No, sir.
Neelam,
No, sir.
come on. You are a clinical practicing fellow, my sister. Yes, Vidya. Vidya Nair.
No, sir, I don't know, but
Oh, I'm surprised. No problem. But have you heard of it or not? Or even you didn't heard of
absolute
ANC?
neutrophil count, yes.
Okay,
Yes.
Catherine is silent.
Yes, sir, I've heard of it, but I don't know. I'm thinking
Wonderful.
from WBC into something. I'm not sure.
No problem. So I think I selected a good.
Is 100 microliter.
Sorry.
Is first answer is 100 microliter, and just stopped. If a patient's agranulocytosis probably is have high risks of severe infection.
Great. So that's the second question. But first question is that how to calculate. So remember, no need to mug up. Say for example here, just listen the one example. You can calculate any things. Platelet count is 250,000. I did not post it, but anyway, out of neutrophil is 10%. So simple, doctor. Simple. Out of 2000 WBC, this is total WBC count. Am I right or wrong? This is total count is total WBC count. And in total WBC count, there are 5 components: neutrophil, eosinophil, basophil, lymphocyte, and monocyte. I had given all the 5. Amongst this 2000, 10% is the neutrophil. 10% is neutrophil. So simple, right? 2000 total count, right? This is total count. This is neutrophil 10%. Multiply by 100. 1, 2, 1, 2. So here the absolute neutrophil count is 200. Is that clear? Yes or no? Total WBC
Yes.
count multiply by neutrophil divided by 100. So if it is a scenario is changed here 4000, say for example. So 4000 total count, 10% neutrophil divided by 100. So now here the ANC is 400. Simple. If it is 8000, so 8000 multiplied by 10 divided by 100, it is 800. Is that clear or not? Yes or no? Tell me at least yes or no.
Yes, sir.
Yes, sir. Yes, sir.
Yes.
So the same way you can do for the eosinophil. This is absolute neutrophil count. This is absolute eosinophil count, absolute basophil count, absolute lymphocyte count, and absolute monocyte count. Is that clear? Whatever they ask, this is formula. Total count multiply by whatever they ask divided by 100. If they ask total absolute neutrophil count, put it here the neutrophil. They ask absolute eosinophil count, put it eosinophil. If they ask absolute lymphocyte count, put it lymphocyte count. These two will not change. Total count and this will not change. Here the number change. So what you need to do in exam, you need to concentrate what they ask. If they ask absolute neutrophil count, put it here neutrophil. If they ask absolute lymphocyte count, put it here lymphocyte. If there's absolute eosinophil count, put it here eosinophil. Is that clear? Yes or no?
Yes, sir.
Yes or
Yes.
no? Now, so answer
Yes,
of this
sir.
question is the 200 absolute neutrophil count. Now, what's the question? What is agranulocytosis? First of all, anyone, open for all. We are 50 people in house. What do you mean by agranulocytosis? Have you heard of this condition or not? Yes or no?
Yes, sir.
Yeah, what is that?
So the granules like this colony forming, that those will be lost. Like for example, this WBCs all will be reduced.
WBC is reduced. Okay, great. It is reduced, but is there any demarcation, any line? Reduce means how much reduce? Less than 100, less than 200, less than 300, less than 500, less than 1000. What exactly you mean by agranulocytosis? So no need to mug up. A means absence. Anywhere is absence. Now in medical term, agranulocytosis. right? And granulocytosis means neutrophil, because neutrophil is a granules. Na? There are two things, right? If you go to the MBBS, in WBC, there are two, agranulocytosis and granulocytosis. So granulocytosis 3, neutrophil, eosinophil, basophil, and agranulocytosis, lymphocyte and monocyte. All together is a WBC, all 5 differential count of. What is the difference in agranulocytosis? This is lymphocyte and this is nucleus. So there is no granules in the cytoplasm. That is why it is called agranulocytosis. And granulocytosis is what? In neutrophil, this is nucleus, and there are lots of granules in the cytoplasm. So it is there in neutrophil, granules is there in eosinophil, granule is there in basophil. That is why it is a granulocytosis. In lymphocyte, no granules in cytoplasm. Monocyte, no granules in cytoplasm. That is why it is a agranulocytosis. I mean, agranulocytosis, the granules are less basically. Is that clear? So agranulocytosis definition is when you have less than 200. It is very critical, called as a very critical 100. Sorry, agranulocytosis is a condition in which the absolute neutrophil count. Now you get to know, right, how to count the absolute neutrophil count. Again, absolute neutrophil count is equal to total WBC count or total count divided by 100 multiplied by percentage of neutrophil. Simple. Here 2000 was the total WBC count, 10% was the neutrophil divided by 100. So our score is 200. So it is a very low, but definition is what? Agranulocytosis is 100 neutrophils per microliter of blood. Agranulocytosis may be acquired or inherited. It is a serious condition and can be life-threatening. Prompt diagnosis and treatments are needed to avoid mortality due to septicemia. Because what is the which blood cells fight against infection in the body? In WBC, mainly the neutrophil and then lymphocyte, right? Everybody is important, but neutrophil and lymphocyte are the two key factors which fights against infection. And what happens when the neutrophils are not there? Anything what enters into the body, who kills the bacteria, who kills the virus, who kills the organism, who kills the foreign body, is a neutrophil and lymphocyte. But think of, there is a no neutrophil in your body, no lymphocyte in your body. Example is HIV. There is a CD4, CD8 cell count. That is a T helper cell or T lymphocyte. T lymphocytes are not there. What happens? HIV patient easily get the opportunistic infection. Have you heard of it or not? Yes or no? Right? Why it is developed? Because of the opportunistic infection. There is no nothing inside this, right? And that is why the thing is. So you must know the neutrophil things. And this is the basic things what I explained you. So not going much in detail. These are the various classification of agranulocytosis, right? As I mentioned you. So less than 500 is bad. 500 to 100, 1000 is okay. 1000 to 1000 is, this is milder form. This is even better than this is, because here the ANC is good. This is absolute neutrophil count between 1000 to 1500, and normal in your and my body is more than 1500. More than 1500 ANC is normal. 1500 to 1000 is mild. 1000 to 500 is moderate, severe, and in my language, fourth category, super severe, less than 100. That is called agranulocytosis. Here it increases the risk of infection, and especially you are on steroid, you have multiple comorbidities, you have diabetes, you have other problems, then this increase will be doubled, because already you have agranulocytosis and on top of that you have diabetes. So again, it's a more trouble, right? So this is how. So every patient, if you are working in clinic, try to cultivate the practice of doing ANC from tomorrow while you are going to the round, right? CBC is there in every patient. Those patients who admitted, if if your doctor will do only one investigation, then it is a CBC. So you must know the CBC. If you are interested more in how to interpret the CBC, we have one another different lecture, but that will concentrate only on CBC. So tell me if you are guys are interested. So I'll go a bit in detail of only CBC, no other here and there. Radiation exposure does not cause. So radiation or radiotherapy. Have you heard of radiotherapy? So when there is a cancer patient, we treat cancer patient with the surgery. We treat the cancer patient with the chemotherapy, and we treat the cancer patient with a radiation or radiotherapy or radiation. Is that clear? So this radiation exposure does not cause this, means it cause everything, but there is a one thing which does not cause the radiation. What is that?
CLL.
Wonderful. 100%. Super. CLL. So radiation exposure can cause AML and CML. It also causes ALL, but it does not cause the CLL. So this is the answer, CLL. Recently asked question in exam. Radiation does not cause which leukemia? So answer is CLL. It can cause AML, ALL and CML, but not CLL, right? Filgrastim is used for the treatment of what? Neutropenia, anemia, polycythemia, neutrophilia.
Neutropenia, that is granulocyte stimulating
Okay,
factor.
okay, great,
Granulocyte stimulating formation of it.
great, great, great. So filgrastim, this is simple questions anyway, but I'm happy at least you knows. So I'm very happy. So filgrastim. So let me tell you a little bit more detail. So in the CBC, there are three things: hemoglobin, white blood cell, and platelet count. So when there is a WBC counts are low, or agranulocytosis, or neutropenia. So again, neutrophil is normal or it is high. When neutrophil is high, it is called as a neutrophilia. Am I right or wrong? And when neutrophil is low, it is called neutropenia. Am I right or wrong? Yes or no?
Right, sir. Yes.
Great. So here when the neutrophil is low or WBC is low, there is a one injection which is called as a filgrastim. So if you give the filgrastim, right, another name is a GCSF or GMCSF, granulocyte colony stimulating factor. So this synthetic injections which given subcutaneously to the leukemia or lymphoma or any solid cancer patient, those neutrophil counts are low. It try to improve the neutrophil count, and it is known pharmac name is filgrastim. If your hemoglobin is normal, if it is hemoglobin is low, it is called anemia. If it is very high, it is called polycythemia vera. Am I right or wrong?
Yes, sir.
Right. So what you will give, like for WBC low, you give filgrastim. So if HB is low, what will you give?
Iron replacement or blood volume.
So basically, first find out the cause, right? Because B12 deficiency, if you give iron, it won't help. So treat the cause. But if I tell you low hemoglobin with chronic renal failure patient, what will you give? Low hemoglobin with chronic renal failure, what will you give?
Erythropoietin.
Excellent, excellent, excellent. EPO or erythropoietin. So when there is an anemia of chronic disease, where you supposed to use the erythropoietin. In iron deficiency, you don't need to give erythropoietin, right? When you have iron deficiency, give iron. When you have B12 deficiency, give B12. Why you want to give the erythropoietin? Erythropoietin in chronic renal failure, because in the kidney, right? Erythropoietin is a hormone produced from the kidney. 99% of the body's erythropoietin is produced in kidney. Small amount, 1% or so, produced in the liver. Right? So when the kidney is failed or kidney is in failure or chronic renal failure or chronic kidney disease, this erythropoietin production is stopped because kidney is no more producing erythropoietin, and biggest functions of the erythropoietin is to stimulate the erythropoiesis for the formation of hemoglobin. Is that clear? Yes or no? Tell me.
Yes, yes.
So
Yes,
if there is a no
Yes, yes.
erythropoietin, then there is a no erythropoiesis, then will be a no hemoglobin generation. So if you want to generate the hemoglobin, you give the erythropoietin in a kidney disease, it will stimulate the erythropoiesis and it will increase the hemoglobin. That's it. No need to mug up. How the erythropoietin works, I told you in a one line, right? So when there is a low WBC count, you use the filgrastim. When there is a low hemoglobin, especially in two condition, anemia of chronic disease or chronic renal failure, right, you use the thing. So WBC, RBC and platelet. So what you use in a platelet count when it is low, then there is a april vaccine, interleukin 11. is used, right, to prevent and treat the thrombocytopenia as well. So this is the very important and common questions asked in exam. So you must remember how you deal or how you improve hemoglobin, white cell and platelet, especially when they are low, and that's it. Is that clear? Yes or no? Yes or no?
If a low platelet count, if it is bleeding, we infuse,
Yeah, so
we
there
do
are a
the
lot of,
transfusion.
yeah, so it's a good questions. Let me little. So this is one thing. When patient has a thrombocytopenia or low platelet count, patient is bleeding, immediately what you can see, PRC, PAC, right? Platelet rich concentrate, or another is a large volume is SDP, single donor platelet. So these are the two products like blood transfusion. You transfuse the blood, right? When patient has 4 gram of hemoglobin, road traffic accident, hypovolemic shock, and HB4, you order fast 3 or 4 transfusion, isn't it? Same way, thrombocytopenia, when patient is bleeding, you order either PRC, that is platelet rich concentrate, and another is SDP, called as a single donor platelet. And also, obviously, you need to treat underlying causes. That is for sure, definitely, right? But in emergency, this is how we treat the patient. Like patient present to you with 104 degree of temperature, right? So you have to give some paracetamol or febrinil, right? But the same time, you need to do the diagnostic workup for hyperpyrexia as well. Which of the following laboratory tests differentiate leukomoid reaction and chronic myeloid leukemia? LAP leukocyte alkaline phosphatase, LCA leukocyte common antigen, MPO myeloperoxidase enzyme, and TRAP, that is a tartrate resistant alkaline phosphate. So understand the questions. These are the 4. Which of the following laboratory test, means there is a one test you have to pick up, which differentiate between leukomoid reaction and leukemia? So anyone who is answering me, they have to answer me what is leukomoid reaction, what is CML. Sanjida, any idea?
Doctor, I don't know what leukemia reaction is. This is
Have
my
you
first
have
time.
you have you heard, doctor? Just I'm curious about knowing. Have you heard of this word leukemoid reaction in your clinical practice?
No, we didn't do all.
You never ever heard of
s-
leukemoid reaction?
No, like we
Oh,
didn't do it
uh,
in our even like internship and everything. We didn't do all.
sorry. Can you repeat it? Sorry, I missed the word.
I'm saying during our internship as well, we didn't do all this. No, we heard of this.
Fair enough. Fair enough. No worries. This is what the learning platform. That is what we are doing.
so
Anyway, yes.
can I guess? I think leukemia reaction is the increase of WBC. Uh,
So WBC is also increase in CML.
yeah, but it will be. They used to remove the WBC when the CML is causing heavy WBC. No, sir.
Sorry, I'm still not getting exact things what you are trying to convince
Uh,
me.
yes, sir. It's like we used to remove leukemia reaction is like WBC is very high, and we try to remove WBC in the first place in the CML before diagnosing. When we see the WBC, and
So
we used to
can you
remove very high,
can you tell me very high means what? 1 lakh, 2 lakh, 5 lakh, 10 lakh, 20
more
lakh.
than 20, 2 lakhs.
More than 2 lakhs is a leukomoid reaction or
I
Yes,
guess
CML.
so. So
leukomoid.
CML, it is 5,000 for 50,000. It seems so. I guess
Hmm.
50,000.
Okay, so this is
More
one
than
difference.
50,000.
Okay, fine, fair enough. And anything? Anyone?
Leukomoid reaction is based on infective pathology.
Okay, infective pathology. Okay, what else? Just the infective pathology. So how you differentiate under microscope that, okay, fine, this is leukomoid reaction, this is CML.
In CML, we see all stages of neutrophil.
Excellent. What are the all stages of neutrophil?
Metamyelocyte, myelocyte.
Wonderful, very wonderful. So all premature cells, what see in the bone marrow can see in the blood, right? So in our hematology field, what we called CML is what? One line definition of CML is bone marrow in the blood. Bone marrow in the blood. Bone marrow in the blood is a CML. You understand? So basically, leukemoid reaction is differentiated by many ways. Let me tell you, leukemoid reaction. This is leukemoid reaction, and this is CML. So first thing, as we say, leukemoid reaction. So some kind of reaction. It resembles like leukemia, but it is not a leukemia. You understand? It resembles like leukemia, but it is not a leukemia. It's a leukemia-like reaction or leukemoid reaction. So if you go by CBC, first of all, total count is usually not more than 50,000. Maximum they go up to 50,000. And in CML, it can go from 50,000 to 500,000. I've seen patient with 500,000 in my practice in CML with splenomegaly, right? So this is one differentiation point between leukemoid reaction and leukemia. Second number differentiation point between leukemoid reaction and leukemia, in peripheral smear you may see toxic granules in WBC, right? Because of the infection. The commonest mechanism of leukemoid reaction is the infection. Commonest etiology is infection, right? Here third point, commonest etiology is infection. Here the commonest etiology is a bone marrow or stem cell problem. You don't see a toxic granules in the CML. Fourth, in leukemoid reaction, there is a no organomegaly. You cannot see hepatomegaly. You cannot see the splenomegaly, means no organomegaly. And here the organomegaly, either hepatomegaly or splenomegaly is present, right, in the leukemia, right? And this, so this is all the basic differentiating point between leukemoid reaction and leukemia. So history is important. They usually present with a fever and fever. Usually here the presentation is usually fever, like fever, upper respiratory tract infections, pneumonia, septicemia, stress to the patient, steroid, DIC, disseminated intravascular coagulation, where what happens? Your WBC count is 4,000 to 10,000. But because of the stress on the body, because of the infection, bone marrow is trying to produce more neutrophil to fight against the infection. And that is why this 10,000 will go up to 50,000. But it won't go 50,000 to 100,000 or 200,000. This is something wrong in the bone marrow, and that is a leukemia, either CLL or CML, right? So that's it. So this is what the thing is, right? So this is the basic, just excellent slide I got it for you as an educational purpose. So I thought, let me share this slide with you, right? I will share with you. So leukemoid reaction, as you see, total WBC count is usually not more than 50,000 a year, more than 100,000, and there is no upper limit. I have seen the patient who has a 500,000 and we treated and he is fine. Basophilia usually not seen. Why? As you doctors, some doctor told, right? There is a premature cell here. Basophilia is usually see. Eosinophilia is not see here. Eosinophilia usually not see. This is a lab score. There is a one score lab score. Leukocyte, alkaline phosphate. Lab score leukocyte, or some people say neutrophil alkaline phosphate. Both are same thing. Leukocyte, neutrophil. Anyway, so lab score is in leukemia is reduced, and in lab score here, leukocyte or neutrophil alkaline phosphate is increased. This is the biggest difference. So here the lab score is increased, here the lab score is decreased. So if you want to differentiate between leukemia and leukemia reaction, you do one test called as a leukocyte alkaline phosphate, right? So what is that? Leukocyte alkaline phosphate. So this is a leukocyte, this is a WBC, 5-lobe WBC, right? So here you put the chemical and see how the leukocyte out of 100 neutrophil, how much will stain with LAR, leukocyte alkaline phosphate is enzyme, right? Stain. So if it is less than 20, it is LAP, and it is more than 150, it is a leukemoid reaction. And Philadelphia chromosome is absolutely negative. Why? Because leukemoid is not CML, so PH chromosome is negative. If it is CML, it is positive. And splenomegaly, as I told you, organomegaly is absent in leukemoid reaction, which is present in leukemia. Is that clear to everyone? Yes or no? Tell me yes or no at least.
Yes.
Yes.
Sanjida,
Yes,
got the point?
Yes, doctor.
You got the point?
Yes, sir. Very nicely.
Very well. You all are brilliant. Wonderful. 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 So this is the thing for, so what the test, gets back to the question, which of the following laboratory tests differentiate leukemoid reaction from leukemia? So an answer is LAP. Is that clear? Right? So answer is LAP, leukocyte alkaline phosphate, that differentiate, right? So let's go little things. So these are the things, there are the conditions in which LAP increase, LAP decrease. But the important thing I want to tell you is, so this is important. This LAP is an enzyme present in a mature neutrophil. So this is most important word, mature neutrophil. Mature neutrophil. And in leukemoid reaction, the neutrophils are mature, and leukemia, it is a premature. And because of that, premature WBC or premature neutrophil will not be stained by leukocyte alkaline phosphate, and that is why it is low. And here 50,000 count, all neutrophils are matured lymphocyte, neutrophil. And if you stain with leukocyte alkaline phosphate, it will stain. So LAR is high because of mature. Here it is immature, so they will not stain. That is how it comes. So enzyme, what enzyme? Leukocyte alkaline phosphate enzyme present in the mature neutrophil, either reactive or inflammatory, but absent, LAP absent or low in immature neutrophil, and CML is the immature neutrophil. That's it. That's it. Right? So this is the science. Is that clear? Yes or no? Yes or no?
Yes, sir. Yes, sir.
Yes, sir.
Wonderful. DIC is seen in the following type AML: AML M3, AML M4, AML M2, AML 5. So this is first question, and then 7 questions, which you can read it.
M3. M3.
Who is the volunteer for this question? Who is the volunteer for this question?
Yes, sir.
What's your name?
Dr. Preeti.
I think you are a hematologist. 1 minute. Huh? Yes, volunteer. Who is the volunteer?
Yes, sir.
Okay. Sorry, what's your name?
Dr. Preeti.
Dr. Preeti. Sorry, huh? If I forget your name. So Dr. Preeti will be the in charge of this whole MCQ. First question, Dr. Preeti. How many subtype of AML? AML is acute myeloid leukemia. So do you know any classification or total this M3, M4, M2 and M5? Only 4
Totally 7, sir.
7. So there is a M0 to M7 is a total subtype of AML, and the classification is 2 classification available in the world: FAB, French, American and British, and another is a WHO classification. So these 2 classifications are available to classify AML in a various category like M0, M1, M2, M3, M4, M5, 6 and 7, right? So now what's the question here? DIC is seen in which of the following type of AML. So you have total M0 to M7 category. Right here only 4 ligand, but if you write down M0, M1, M2, 3, 4, 5, 6, and 7, so all 7 category, what is the answer? Number 1.
M3 is the answer, sir.
M3. What is the M3 means? Is there any name
It is
for AML M3? There is one name of this leukemia.
At acute promyelocytic leukemia, sir.
So it is also known as a APL or acute promyelocytic leukemia. Promyelocytic leukemia means there are more than 20% of the promyelocyte is seen in the bone marrow aspiration, right? Or right. So it's a plentiful of promyelocyte in leukemia. So it is APL. So this is the answer. And APL or acute promyelocytic leukemia is a M3 subcategory. So M3 is a acute promyelocytic leukemia. Now tell me, Dr. Preeti, why the DIC happen in this only? Why not on M0 to M7, only M3? If you don't know,
Not
just
sure,
say
sir.
don't.
No, sir. No, I do not, sir.
If you want to speak wrong answer, I would be happy. At least you are interacting. I'm extremely happy. Right or wrong is
No,
a different issue. And rather, it's not an issue at all. It's a good, at least you are participating. So anyway, acute promyelocytic leukemia in this promyelocyte and OR rod. You know OR rod? OR rod.
Yes,
Sanjida,
sir.
you know OR rod?
Yes, sir.
So this is a blast cell. This is a neutrophil I'm drawing, or this is right. And there is a OR rod. This is a OR rod. This is a rod-like structure in the cytoplasm, and it is called as a OR rod. And OR rod, AUER, OR rod is the pathognomonic word. What word important is pathognomonic of AML? This is again exam question. They give long scenario, they give you peripheral smear, they see there is a OR rod in the cytoplasm, what's the diagnosis? So if OR rod in cytoplasm, AML, ALL, CML or CLL, what's the diagnosis? What's the diagnosis, Preeti?
AML.
Right, AML, myeloid leukemia, only it is seen in myeloid leukemia, AML. So OR rod is equal to AML, fix in your head, don't get confused between ALL, CML, CLL. OR rod is the pathognomonic of AML. Another, if there is a one is a OR rod, if there are too much of OR rod, do you know what is the name of that?
No, sir.
It is called as a faggot, FAGGOT. This is DNB question. This is little credit question. So if there are too much of OR rods, plentiful of OR rods, right, in a bunch, it is called as a faggot. It is again a AML anyway, but just for your knowledge, it is written in the book very well, clear cut. Anyway, so again go back to the question, AML, M3, because of promyelocyte, plentiful and OR rods. OR rods again see not in all AML, more commonly seen in M3. Is that clear? So that release some chemical which makes the blood thrombogenic, and that is why the DIC is more common in AML. Is that clear? Is that clear, everyone? Yes or no?
Sir. Yes.
Wonderful. So this is a little complicated things, but make it easy. Second thing, best prognosis. One question is finished related with OR rod. This is one exam different question. This OR rod is different question. Faggot is third question. Fourth question is AML DIC is a fourth question. Fifth question comes best prognosis of amongst all AML. So if you have M0 to M7, which AML has the best prognosis? Exam question recently asked.
M0.
No M0. Again, the answer is M3.
M3.
Acute promyelocytic leukemia, amongst all M0 to M7, M3 has the best prognosis. Cure rate is almost 80% or more, right? So this is the best. So don't give the negative counseling to the patient. Oh, AML M3, acute leukemia, now this patient will die, right? There is no treatment. Leukemia cannot be cured. Don't tell that. 80%. Can you imagine 80%? Diabetes mellitus, what is the cure rate? 0%. Acute myeloid leukemia, AML, M3, cure rate is 80%. What do you think? Which one is better? Diabetes or AML?
AML.
AML, because it is 80% cure. Diabetes, lifelong you are keep taking medicine, but you are worried with what? Diabetes you are worried, or blood cancer you are worried?
Diabetes.
But 99% my brother worried from cancer. When you tell somebody cancer, oh cancer, right? It is a mindset. For years and years, people think cancer means cancelled. There is no cure. So it's absolutely cure. So best prognosis answer in exam is M3, AML M3 or APL, acute promyelocytic leukemia. Commonest AML, M0 to M7, which one is the commonest?
M3.
No, common is not M3. Sorry. Common is not M3. Commonest is M2. 30% of the patient has a M2 and rest 70% has M0 to M7. Let me share the slide. Otherwise, you will not believe me, na? If I don't share the slide, will you believe me? Yes or no?
Yes.
I think you are all good, genuine doctors. That is why you 30%. M2. So M2 is common. M3 is just 5%. So if they ask which is the commonest AML, M2. Which is the best prognosis, M3.
M3.
Which is present with DIC, M3.
M3.
Is that clear? All different question. You need to understand. All different. You need to little mindset, your mindset. So this is FAB. French, American, British. M0, M1, M2, M3. So I had given this just slide just for you to understand, right? So I'll share with you. Don't worry. So this is what the classification. I'm not going much detail in classification, but this is what you need to know. So base prognosis is M3. Commonest AML is M2. DIC is common in AML M3. How to categorize AML, right? It's not much important. It's advanced hematology. Leave it. How to treat the high risk AML? So high risk AML first treat with the chemotherapy, and chemotherapy followed by bone marrow transplant. And last but not the least, related with AML, what is the ATRA, Preeti? And what is the use of ATRA? So first of all, tell me what is ATRA. Second, tell me where ATRA is used, in which AML. Yes, tell me.
All trans retinoic acid.
Excellent. So this is all trans retinoic acid. What is it? What this all trans retinoic acid? Where it is used?
AML M3.
AML M3. Excellent. Wonderful. How does it act in AML M3?
Add-on.
Sorry. How does it act? Anybody? Preeti.
Sir, I know that it is an add-on treatment for the rods for the eosinophilic incursion. It will act on, sir.
Sorry, where
I'm
it
not
acts?
sure. I'm not sure. It acts on the M3, and I know that it is an add-on treatment.
Yeah, add-on treatment, but how the ATRA will act on APL, or how it acts? So this is homework anyway. I didn't give you any homework. So just everybody, those who are in class, read the APL M3. Only one thing you read, best prognosis. So you may need to know, you need to counsel your patient. Don't worry, though you have a blood cancer, though you have acute myeloid leukemia, but don't worry, 80% cure rate with this patient. So you go for ahead and treat the patient. He will be cured. Give positive message to the patient. Is that clear? So I'll keep this. Well done, Preeti. Huh? So far, so good. Enjoying?
Yes, sir.
Yes, sir.
You need to check your score. Huh? We did 7 questions and check how much is right, how much is wrong. Dr. Sanjida, are you getting me? Dr. Sanjida, are you there?
Yes, doctor, I'm here.
Great, wonderful. Are you enjoying the class?
Yeah, doctor, very much.
Wonderful, 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 wonderful. Little complex question. Little, don't worry. 2-year-old child comes with a ear discharge, seborrheic dermatitis, polyuria, and hepatosplenomegaly. Which of the following is the most likely diagnosis? Is it leukemia? Is it lymphoma? Is it Langerhans cell histiocytosis? Is it germ cell? What's the diagnosis? What's the treatment? Remember my triad. I probably make patent of my triad. Huh? Diagnosis, investigation, treatment. Yes, Sanjida, any clue? Sanjida,
Um, let
any
me just
answer?
read. Yeah,
Yeah,
okay.
yeah. Take your time. I'm not in hurry. Everybody take the time. Dr. Ansiya, any comment? Dr. Ansiya, are you there in the class? Dr. Jinis, AP.
Yes, sir. I am here.
Yes, Ansiya,
Ansiya.
tell me. I would be happy to hear you. What
Doctor,
do you
is it
feel? Yes, tell me.
C, Langerhans cells histiocytosis?
Okay. So why
Study.
it is not leukemia?
I was thinking of leukemia, but then it just changed because last slide you said leukemia has splenomegaly.
No, no. So you are brilliant. I mean, anyway. So I'm just trying to understand. See, any question, Sanjida, what to do? Now make a habit from today. So say for example, Langerhans is the answer, right? This is answer. Really, this is
Yeah.
answer. So you're right. But the same time, Sanjida, you need to know why it is not leukemia, why it is not lymphoma, why it is not germ cell tumor. You need to exclude the other reasons as well. And this is called as an analytic skill. Why this not? Why this not? Why this not? Why this not? You understand? So when
Yes,
you
sir.
try to do this practice in every MCQ, challenge you. Nobody, whatever they ask, you are 200% pass in exam. 200% guaranteed. Let them ask whatever they want to ask in any exam. Why? Because you have complete clear clarity that okay, fine, this is that, this is that.
Yeah.
Now let me tell you, whenever there is a leukemia, there is a blast cell which is not mentioned in the scenario. Let me tell you, if something is not mentioned in the scenario, means it is absent. If they don't mention about vitals here, means vital is stable. If they don't mention that what is the blood sugar, means sugar is normal. You understand my things, Sanjida? So
Yes, doctor.
there is a no blast cell, right? There is a no blast cell. So leukemia is almost out of the things, right? In leukemia, you usually, I mean, you probably not seen much patient, but I'm doing it for last 20 years. So you won't much see the seborrheic dermatitis in leukemia. You don't see much polyuria in leukemia. You cannot see. Okay, you can see sometime in leukemia, either myeloid or lymphoid. You can see hepatosplenomegaly. That's okay. But leukemia is again very rare at the age of 2 years. Not common at 2 years of age leukemia, right? So these are the point against leukemia. So that is why this is how you have to do practice for each and every question. Why it is not lymphoma? Again, lymphoma, there are two types, Hodgkin's lymphoma and non-Hodgkin's lymphoma. There is no Reed RS cell or Reed Sternberg cell not seen. Here they have not mentioned anything. It is not seen in 2 years. Again, little against it. Germ cell tumor against it. This is classical Langerhans histiocytosis. Langerhans cells histiocytosis is a rare condition that can damage the tissue or cause the lesion to form in one or more places in the body. Langerhans cell histiocytosis is rare with LCH cell. LCH cells are a type of dendritical cell that normally helps to fight infection. What is a classical combination in seborrheic dermatitis? Polyuria, hepatosplenomegaly, ear discharge suggest or diagnosis of Langerhans. It's a triad. What is the drug of choice? Second question in exam. What is the drug of choice of Langerhans? Standard therapy for Langerhans cell histiocytosis are vinblastine. It's a chemotherapy. Prednisone is a steroid. with or without methotrexate, with or without methotrexate. So these all are the immunosuppressant drug which can be used to treat a Langerhans histiocytosis. So don't ignore any MCQ. They can ask you, let me tell you, in any exam, either DHA, hard or MOH, DHA, hard, MOH or any exam, 70% questions are easy, 20% are toxic, little weird, and 10% are very toxic. So I'm not concentrating. Say, for example, you are not good in this, but I want you get out of this 70%, 65%, you pass. You pass, easily pass. But what do? Will not attempt this because we don't know this. And out of this 70, we do own a very good silly mistake. A, B, C, A, B, C, A, B, C, we confuse. Don't get confused. Easy, I need 70 out of 70. Even if you get 65, you are pass. Simple logic, simple. So don't get confused where your area of interest or your subjects are strong. But I have seen many students, right? Before reading the question, they are more in hurry to give the answer. They have not read the question. They are in more hurry to give the answer. Let me spend 30 seconds for that. So in any scenario, if you are come across in exam, you have 90 seconds. For one MCQ, you have 90 seconds. Spend 88 seconds in reading the question. Because if you don't read the questions, you don't interpret in your brain, you don't know what's the diagnosis, you don't know what's the investigation, if you don't know what's the treatment, 99% chance that you end up with the wrong answer. So don't be in a hurry. What you do the reverse. You read, you don't read, you are in hurry to give the answer. Never ever do that. Completely from first line to last line, spend 88 seconds in completely. How much time you need to click the computer button? 2 seconds. 2 seconds. So here add 2 seconds to clicking the computer. 90 seconds, go to the second question. Repeat the same thing. Go to the third question. Don't do any hurry in giving the answer anytime. Even if you are doing the practice, don't be in the hurry. Understand MCQ. If you understand MCQ, if you properly read the MCQ, only MCQ will give you the answer. Answer is within the question. But when we'll get the answer? When we read the question. We don't read the question, we don't get the answer. As simple as that. So don't be in a hurry to give the answer. Read the question. Sanjida, are you clear?
Yes, doctor, I am. Yes.
Now you answer this question, Sanjida. I'm reading on behalf of you. A diabetic female on INH. You know INH? Sanjida, you know
Yes,
INH?
sir.
No,
INH, yes, doctor.
let the Sanjida to answer. It's a learning platform, so let her learn. Yes, what is INH?
INH, is it this thing, the isoniazide, those
Excellent.
drugs?
It's an anti-tubercular drug, ATT or AKT, anti-COX treatment, isoniazide, right? What is the commonest complication or side effect of isoniazide? There are thousands of questions in one question. Even I can spend 2 hours in one question.
Lupus.
No. Let this
Lupus
Sanjida to
nephritis.
answer. I want Sanjida only.
Isoniazide side effects, I don't remember, but I remember so far there used to be nausea, vomiting,
No, that is a
joint.
general. That is for every drug. Nausea, vomiting is in every drug. What is the specific side effect? So your homework, Sanjida, your homework,
Peripheral neuropathy.
right? So your homework is to read all, not a. There are isoniazide, rifampicin,
All the
ethambutol,
triple.
pyrazinamide, INH, rifampicin, ethambutol, pyrazinamide, and I think streptomycin, isn't it? These are the all standard AKT. So you need to read only adverse effect, one or two. Like this is peripheral neuropathy, somebody told. Like I know each and every, but I want you to tell me by end of the evening. This is your homework.
What are the last two?
So you read AKT basically. INH, rifampicin, ethambutol, pyrazinamide, and streptomycin. Very, very frequently asked questions in exam. Every exam, either they ask ethambutol toxicity or INH toxicity. And let me tell you, not just the toxicity, what's the remedy for that? What's the treatment for that? That they also ask. So you tell me two things, sir. Peripheral neuropathy is a side effect of INH, and this is the treatment. Is that clear?
B6.
Yes, that's correct. Sanjida, are you getting my point?
Yes, doctor. I'm just, yeah.
Great, wonderful. Hope you are not unhappy with me asking you
No,
a lot of
doctor, I'm
questions.
really happy. I'm happy. I like the interaction. It keeps you
Wonderful,
awake.
wonderful. So you go ahead. This is your question. So you have a one diabetic female on INH, that is isoniazid. Isoniazid commonest side effect is peripheral neuropathy and treatment is B6. Pyridoxine. You should give prophylactic pyridoxine. Not related with this, but for your understanding. So diabetic female on INH and rifampicin for TB. And now she developed. Now she started on warfarin. Patient is not PT. What do you mean by PT? Have you heard of PT? Sanjida.
Prothrombin time.
Sanjida, my brother. Sanjida only.
Prothrombin.
Huh? PT means?
Prothrombin time.
Prothrombin time. PTT means? Sanjida only.
Prothrombin time, this thing. Prothrombin time test.
Prothrombin, this is prothrombin time. So
Yeah.
what is this? Prothrombin time test?
Yeah.
Are you sure?
No. No.
Anyone, let other expert, listen other expert. What do you mean by PTT?
Partial thromboplastin.
P for, not P for prothrombin, it's a partial. T for?
Thromboplastin.
Thromboplastin. And T for?
Time.
Time. Have you heard sometime they mention A in front of PTT? Have you heard or have you seen this APTT? Yes or no? Tell me at
Yes,
least
sir.
yes or no.
Yes, yes.
A stands for activated.
Activated.
Sanjida, are you clear?
Yes, doctor.
Second homework. What is PT? What is APTT? Until and unless I give you exam, probably you will enjoy in Dubai. So now tell me, Sanjida, a diabetic female on INH and rifampicin for tuberculosis. Now she started on warfarin, and warfarin, once she started PT, prothrombin time is not raised. What will you do the next? Increase the dose of warfarin, replace the warfarin with the acinocumarin, switch the ethambutol from rifampicin. So now you stop the rifampicin, let me finish, and then you stop rifampicin and you add the ethambutol. So now you give INH, ethambutol, and warfarin. You switch one drug or you use LMWH or low molecular weight heparin. You stop warfarin, you start heparin. Tell me now.
First of all, we will not replace warfarin with acinocumarin, B for short.
So B is gone, right?
Yeah.
Okay, so let me
The answer is
exclude one
A,
by
but I'm
one.
just telling. The
No,
answer
no,
is
that's
A.
fine. So this is gone. Okay.
Yeah. And then, yeah, switch ethambutol for rifampicin. I'm not sure about that, but I don't think that's an answer either.
Okay, so that is also gone.
So we're stuck with A or D, right?
Okay, so you decide what you want to do.
I think we'd go for A, increased dose of warfarin.
Yeah, that is the answer. But why not warfarin? Why not heparin? Why you want to increase the dose?
Because prothrombin time is not raised, right? It should be raised with the warfarin. So we just try with increasing the dose of warfarin.
Great, wonderful. Now, one more important logical question. What do you think, what went wrong? Why the PT is not raised? Once you start the warfarin, PT prothrombin time will raise, but why it is not raised in this case?
Cause of rifampicin.
Sorry?
Rifampicin is an enzyme inducer.
Drug interaction.
Great. So this is the biggest example of drug interaction. Anti-tuberculous drug means INH, rifampicin and warfarin. is an enzyme inducer. So it reduces the activity of warfarin. It reduces the activity of warfarin, and that is why warfarin activity, how you monitor that warfarin is working well or not? By PT, prothrombin time. So it is already patient tuberculosis, now develop some clot, I guess, right? So they started warfarin. After starting the warfarin, they are monitoring PT, but it is not raised, right? Because this drug interaction, it reduces as an enzyme inducer, it reduces the activity of warfarin. So little higher dose of warfarin is required. So your first job is to increase the dose of warfarin, Sanjida. You are right, but this is the logic. You understood? Yes or no?
Yes, sir.
Got it. So this is very important questions, right? So warfarin acts on which clotting factor, Sanjida? So this MCQ is done. Increase the dose of warfarin. Why? Because it reduces the activity of warfarin. So you increase the dose. That is the first. And any this is general in pharmacology. I'll give you one tip. Pharmacology. Any drug. This is not warfarin. Any drug, whatever the drugs available in the world, when you start with the minimal dose, if not improving with the minimal dose, increase the dose and go up to the maximum dose. Is that clear? This is a
Yes,
common
sir.
this is a common concept. And even with the maximum dose, you don't get the effect, then you change the drug. You have hypertension, blood pressure is 200. You start amlodipine, 5 milligram, 200 to 180. Okay, getting better. 10 milligram, 160. 20 milligram maximum dose, still 160, not reducing. So you add another drug. That's it. Go up to the optimal dose, then either remove or add another drug. This is a very common concept in pharmacology, right? So you can't stop immediately. Oh, you stop TB drug. If you stop the TB drug, then how the tuberculosis will be taken care of? No, right? So you continue this, but try to do the increase the PT, because PT they have started warfarin because there must be some logic, there must be some clot which is not mentioned here anyway. So this is what you need to understand, right? So basic concept for any pharmacology is start with the minimal dose. If not improving, go gradually to high dose and go up to the maximum recommended dose. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Yes, Sanjida. So now tell me, warfarin acts on which clotting factor? Do you know clotting factor, Sanjida?
Factor
Yes,
8.
sir.
Let her
It
finish.
acts, it
Yes,
acts
Sanjida.
on it acts
Tell,
on vitamin D. Yeah.
so first of all, tell me there are how many clotting factors are there?
How many clotting factors are there? Like
If you don't know, this is homework. Second question. Warfarin acts on which clotting factor? Do you know, yes or no?
yeah, that I know.
Yes, tell me.
That it depends on it's on vitamin K dependent clotting factors. That is 2, then 7 and 9 and I think 10. The vitamin K dependent clotting factors and the anticoagulant proteins C and S.
I'm giving you 10 out of 10.
Thank you.
Warfarin is basically a vitamin K warfarin antagonist is vitamin K. So when you give vitamin K, it acts on the vitamin K dependent clotting factor, and these are the vitamin K dependent clotting factor. This factor will clot the blood and it is an anticoagulant drug. So if you inhibit, it will do the anticoagulant effect. So far clear? Yes or no? Yes or no? Yes or no? Yes, doctor. Sanjida, what is the warfarin antidote? Say, for example, if you have a patient who has a toxicity of warfarin, right? So, what is the antidote of toxic warfarin? Warfarin is overdose, right? Very, very high toxic dose of warfarin patient received. What is the first of all toxicity? What is the toxicity of warfarin? If warfarin is given in high dose, what happens to the patient?
Bleeding.
Sanjida,
I'm actually unaware of it, doctor.
bleeding, simple bleeding.
Oh, it.
Yeah, because right, you are and warfarin is an anticoagulant drug, so it will not allow the blood to clot, right? So it's a bleeding is a major complication of the drug. So if patient present to you in emergency, right? Patient is on warfarin for, say, for example, deep vein thrombosis, you had given the warfarin, right?
Yeah.
Warfarin you had given, you monitor PT, PT is 20, and patient is bleeding, GI bleed. What will you do?
Give vitamin K.
Vitamin K.
Okay, so first of all, antidote is vitamin K. If vitamin K you had given optimal dose, vitamin K is not working, what will you do next?
Tranexamic
FFP.
acid.
Sorry, Sanjida.
Tranexamic acid maybe.
Tranexamic acid is not antidote, it's antifibrinolytic drug, so it will not help much.
Blood product.
Prothrombin
FFP.
complex.
So prothrombin complex concentrate is last, but before that you can use the FFP, fresh frozen plasma, right? FFP, fresh frozen plasma, because this fresh frozen plasma contain all the factors which are there formed in liver, 2, 7, 9, 10, right? So it will replace the 2, 7, 9, 10 by giving the FFP. So first give the vitamin K 100% undoubtedly. If no response, use FFP as well, and prothrombin complex concentrator also you can use as well. These all are the IV products, right? So warfarin acts on these factors, as Sanjida told. Antidote of warfarin is a vitamin K, but in case of bleeding and toxicity of warfarin, you can use the FFP and PCC. How to manage the warfarin toxicity? Excellent chart I'll show you, right? This is a frequently asked questions in the exam, and very, very important practically, because if you are in hospital setup and if you are in ICU, you have definitely 100% patient with a clot or DVT or pulmonary embolism, where you gonna use this warfarin. So warfarin, first of all, let me tell you, normal PT, there is a called as a taste and control. Taste and control. Understand this logic. It's not in the book, believe me, or it's hard time to get this basic concept. So say for example, this is Dr. Munjal. It's my PT only. I'm doing my PT. So control is what? Control is in the lab. It is 16 and taste is my. This is standard, right? This is standard. Normal individual is control, right? And taste is mine, patient 12. So there must be a 4-second difference. Plus or minus 4 seconds is normal. Taste versus control. Is that clear to everyone? Yes or no?
Yes.
Now one patient in ICU whose PT taste is 26 and control is 16. Difference is 10 seconds. Anything more than 4-second difference is abnormal PT. Is that clear? Yes or no?
Yes.
Here, if you do INR, maximum
More than
1.2 is a normal. Any right? So normal INR, if you do Dr. Munjal's things, it should be 1.2. Now see, normal is 1.2. Patient is on warfarin. What's the goal? 2 to 3. Patient is on the warfarin. The goal is 2 to 3 because you want to achieve the anticoagulant effect. If it is less than 2, it is not effective. It is more than 2, it is over effective or risk of bleeding. Is that clear, Sanjida? Yes or no? So far, yes or no?
Yes, doctor, it is.
Got it. So now normal is 1.2, on warfarin 2 to 3. But now this gentleman, now what happens if it is more than 3 then? This is the chart. More than 3, but less than 5. 5 to 9, more than 9 or 10, serious bleeding. So less than 5, no significant bleeding, no significant bleeding. Don't much worried, right? Adjust the dose of warfarin. Say for example, patient on 10 milligram, INR is 4.5, high. What we need, target on warfarin 2 to 3. This is therapeutic. We don't need more than 3. It is 4.5, reduced from 7.5 to warfarin 7.5. Repeat after 72 hours. If it is still high, say for example 4, reduced to 5 milligram. Most of the patient in India, they start, I start usually for many years with the 5 milligram, and by adjusting the dose maximum 10. So within 5 to 10, 95% of my patients are maintaining the therapeutic range between 2 to 3 INR. Is that clear? Yes or no?
Yes.
Right? So if I don't get the effect on 5, I will increase to 7.5. I increase to 10. Now it is between 2 to 3. I'm happy. I'll maintain this 10 for at least 6 months, 12 months, depend on indication. Is that clear? So 5 less than 5, no significant bleeding. You don't need to add any drug. You just need to adjust the dose. 5 to 9, again no bleeding. Hold the dose of warfarin. Means don't give the one dose of warfarin because it is high, right? And once it is normal, resume the lower dose. Resume the lower dose. Example, you started on 7.5 milligram. INR is 9. Next day, don't give the warfarin, right? And repeat after 48 hours. If it is reducing, say for example 8, right? 8, right? Again don't give warfarin till it comes less than 5. Once it is less than 5, start with the lower dose. So here what's the guideline? Less than 5, you don't need to do anything. Just reduce the dose. Here you stop the drug and reduce the dose. Two things. Here just reduce the dose or adjust the dose. Here adjust the dose and lower the dose. You need to reduce. Why? Because INR is going high. More INR, more bleeding. Here more than 9. With or without bleeding, discontinue warfarin. You stop. Then what you do? Not just stop. Only stopping will not slow down. Na? It is already 10. So what you do? FFP, as I told you, fresh frozen plasma you can use, or you can give the factor 7, recombinant factor 7 you can see. And in severe bleeding, this is the worst one. This is the worst one. Any patient on warfarin came with intracranial hemorrhage. Patient on warfarin and intracranial hemorrhage. This is serious bleeding at any INR. So if patient has a intracranial bleeding with warfarin, whatever the PT-INR is there, it's serious. Discontinue the warfarin. You can give the FFP and give factor 7 and prothrombin complex concentrate. Sanjida.
Doctor.
Any
Doctor,
question?
from the last one, when you said if there's warfarin and intracranial hemorrhage, so we stop warfarin, right?
100%.
And then we go with fresh frozen plasma and all the other stuff that we discussed before.
Yes. 100%.
Then in INR 5 to 9, if you hold the dose of warfarin, then how do you resume warfarin at a lower dose? Like if we stop it.
Sorry, what's the question?
For INR 5 to 9, when there is
INR
no
5 to 9, yeah, no significant bleeding.
It said that hold the dose of warfarin, like we stop or like
Yeah, hold means stop. You don't give dose like every day you are giving. It is usually given once a day, warfarin, right?
Yeah.
5 milligram today, 5 tomorrow, 5 blah blah. So if that I had given, I check, okay, 5 to 9 today, say for example. So patient has to take the 2 days dose. So don't give the 2 days dose. Hold the dose of warfarin. That is first line, right? And just monitor the PT-INR every 48 hours, right? Once the PT-INR becomes normal, again you have to start the warfarin, but it's with the lower dose. Is that clear? Because if you give the same dose, again there is a risk of going between 5 to 9. Is that clear? Hello?
Yes, doctor. I'm like, okay, doctor. Thank you, doctor.
If you don't understand, ask me again.
Okay, doctor. Sure, I'll ask. Thank you, doctor.
Great.
Hello.
Any question? Yes. Yes, any
Hello,
question?
can you hear me, sir?
Yes, I can hear you very well.
Sir, can you just tell me what is the normal value of INR and how much we have to, can you just repeat it again? Warfarin, how much we have to maintain INR if we are on warfarin?
Tell you. I'll tell you. So normal.
Sorry, I'm very much weak in this topic actually, INR, PTA, PTP.
Okay. Let me tell you one more story. Story means medical. What's your name, doctor? What's your name, doctor? Am I audible?
Hello, yes, sir. Wajiha.
Sorry, Wajia. Okay, sorry. This is the first I draw this chart many times in the class, but still you don't know. I thought I spent more 5 minutes. It would be crystal clear. So have you heard of clotting cascade or clotting pathway, doctor? Have you heard, doctor? Vajia, Dr. Sanjida, have you heard? Intrinsic factor, extrinsic factor, or not?
Yes, sir. You have explained it in your class.
Sanjida. This is extrinsic pathway when there is any, this is called as a coagulation cascade or coagulation chart or coagulation cascade. So complex, very, very toxic. I try to make it in a simpler way. You never ever forget this. If you understand this, you can answer 100 questions with clotting, 100 minimum. Extrinsic pathway, when there is an extrinsic injury, the clotting factor which gets activated, right? So this is extrinsic pathway. When there is an internal injury happens, intrinsic pathway will activate, right? Extrinsic and intrinsic pathway will merge to the common pathway, and then clotting cascade, and eventually the clot will happen here. Is that clear? The simple basic things. So what happens when there are factors? This is called as a clotting factors, and clotting factors is formed in the liver. Clotting factors formed in the liver. What are the factors? In intrinsic factor, remember in a most simplest way, extrinsic pathway is a factor 7. After 7, what happens? 8. After 8, which factor comes? 9. After 9, where it comes? So 10 is here. After 10, what factor will come? 11. After 11, what factor comes? 12. After 12, what factor comes? 13. That is called clot stabilizing factor. Is that clear? It is very simple. No need to mug up. 7. You just need to remember 7, 8, 9, 10 is here. 11, 12, 13. You can see it, isn't it? So far clear, Sanjida? Dr. Vajia, so far clear?
Yes, sir.
Wonderful. Now, this extrinsic pathway is monitored by PT. Intrinsic pathway is monitored by PTT. So anything wrong in the intrinsic pathway, your investigation of choice is PTT. Anything wrong in the extrinsic pathway, your investigation of choice is a PT. Factor 8 deficiency is called as a hemophilia A. Factor 9 deficiency is called hemophilia B. And factor 10 is hemophilia C. Is that clear? Yes or no? Yes or no?
Yes, sir. Yes, sir.
Wonderful. So far it's clear, right? So this is called as a, and now what happens? This 10 plus 5 plus 2. So I remember in that way. 5 multiplied by 2 is 10. So these all are the clotting factors. And here also calcium is also there in a common pathway just to make a blood clot. So factor 7, 8, 9, 10, 5, 2, 11, 12, 13. When there is an injury, 7 will activate 7A, same way 12 activate 12A, 11 activate 12, this activate 11A, this 11 activate 9A, this activate 8A, and this activate 10A. Factor 10A is the major factor, 10A. And this factor 10A will activate prothrombin to thrombin, and thrombin will activate fibrinogen to fibrin clot, and this is how the clot form in our body. This is how the clot form in our body. Anywhere, any factor at problem, any factor has any problem, right? Any factor has any problem. Problem 12, problem in factor 12, 11, 9, 8, 10A, 7, 10, 5, 2, 13. Clot will not happen. Clot will not happen. Any problem. This is absolutely a symmetrical cycle. Something wrong in any factor will not make the blood to clot. Is that clear? And not clot means bleeding. Vajia, are you clear? I'm
Yes,
trying
sir.
my level
Yes,
best
sir.
to make it simplified.
Yes,
Got
sir.
it? Right? So this is how it works. And there are various drugs which acts on the different pathway. So this warfarin, as we told, it acts on the same pathway. Now this is the picture, right? I draw it. This is the real picture. Got it? So this is a real picture, right? So extrinsic, I told you, factor 7. Intrinsic, I told you, right? Factor 8, 9, 10, 11, right? So factor 9, 11, 12, 13 is a clot, I told you, right? 2, 5, 10. So this is a 10, convert to 10A, 2 and 5, 2, 2A, right? Prothrombin, this is prothrombin, to thrombin, this is thrombin, and this fibrinogen to fibrin and fibrin clot. This is I already explained you. Now see the drug. Warfarin is acts on the vitamin K dependent. This 10, 9, 10, 7, and 2. So when you give the vitamin K, it will inhibit this all factor and make the blood thin. But if you give overdose, it become more thinner and there is a risk of bleeding. And that is why the question you were asking me, right? So what is the therapeutic range or what is the therapeutic range? So in normal PT, there is a test and control. Second difference is 4 seconds only. And in terms of INR is 1.2. This is normal. If the patient is on warfarin, right, there is a more than 4 second difference. INR gold therapeutic is 2 to 3. Anything more than, and after this, toxicity of warfarin will develop. So INR from 3, it may go to 5, it may go to 10, it may go to 20. Higher the INR, higher the risk of bleeding. Up to 5, no bleeding, nothing to worry. 5 to 10 critical, anything more than 10 is very, very critical. That patient will die because of bleeding, internal or external. Is that clear?
Yes, sir.
Any confusion in the audience? I think I try my level best to make it more simplified, right? So this is what and how the drug works on these things, right? So this is what the heparin versus warfarin. So heparin, right? This is probably the last questions for discussion. So bear with me 5 minutes. Heparin, right? And versus warfarin. Therapeutic range 2 to 3, here 45 to 70. Warfarin is a oral drug, right? So warfarin versus heparin. So heparin acts on the intrinsic pathway, as I told you. Heparin acts on the intrinsic pathway. Sorry. So see here, heparin. This is heparin. So heparin acts on the intrinsic pathway, right? Because heparin, right? So heparin, and this is monitored by PT and this is monitored by PTT, as I told you, right? So what is the difference between heparin and warfarin? Sorry. So heparin intrinsic pathway, warfarin extrinsic pathway. Heparin is not available orally, it degenerates, so it is intravenous only. This is oral only. Does not crosses the placenta and this is crosses the placenta, and that is why it is a teratogenic pregnancy. So if any pregnant lady become a deep vein thrombosis, and if you want to give the drug, you need to consider, right? There is a question, right? In which trimester the warfarin cannot be given? The answer is a first trimester. In first trimester, you switch to the subcutaneous heparin, because heparin is not crossing the placenta, and if it is not crossing the placenta, it is not make any harmful effect on the drug. So which drug is the safest anticoagulant during pregnancy? Answer is heparin, not warfarin. A rapid onset of action, because it's intravenous, you start immediately. It takes several days, at least 3 days to get its therapeutic effect. Few drug interaction, it has not much few drug interaction. It has plenty full of drug interaction like AKT, INH rifampicin. I discussed. There are like this thousands of drug interaction eliminated renally, eliminated hepatically, or through liver excretion. This is through the renal. So if your kidney is bad, heparin is not a good drug. If your liver is bad, warfarin is not a good drug. And last but not the least, if you have toxicity or overdose, you use protamine. Exam questions. Antidote of heparin, protamine. Antidote of warfarin, vitamin K. Vitamin K. That's all for today. I have lots of more questions, but probably we discuss in the next session. So that's all. Thank you. Thank you very much, everyone, for your kind attention. Now it's little time for the quick feedback for 5-10 minutes before we pack up. I will be happy. The new student who joined the first time to the class and attending my first class. What is the new? Probably the Sanjida. You are the first class of mine. So how was your experience? How was the learning? What is a new thing for you? You can quickly give your feedback. Are you there in the class, Sanjida?
Yes, doctor, I'm here. I'm just seeing the listing. Yeah.
Yeah. So what's your experience in the first class? Well, how was your learning?
It's really good, honestly. It's really good.
So did you learn something new which you didn't know earlier?
Actually, yeah, I did about the leukemia and all of those. Thank you, sir. Thank you, doctor, so much.
Wonderful. Wonderful. Anyone else? Any volunteer?
Sir, it's me, Harsha.
Yes, sir. Sir Spencer, right?
Yes, sir.
Wonderful.
It's my first class too.
Oh,
And
wonderful.
you've put a tremendous work because how to think, that is what has been pointed out, how to approach a question. It's been clearly well explained.
Very
So
nice.
I think it's explanation and everything in one question itself. There are plenty of questions, so
Yeah, this is how we need to do now, because I mean it is not always what is on my website or what I teach that will come in exam. So we need to know nearby vicinity as well. They may ask heparin, they may ask warfarin, they may ask PT, how to monitor, they ask this, they ask antidote. So we try to cover most of the things what they ask in exam, isn't it?
Yeah. So in one question itself, plenty of questions have been dealt. I think many topics are being covered like that.
Wonderful.
And
anything new first time you, I mean, really fascinated or enjoyed anything new which you not come across earlier? Never. So not really, basically. So you know most of the things, right? That's fine, no problem.
No. I think in every question there are plenty of things new to me.
Okay, great, wonderful. So basically you enjoyed, right? It's a good learning session.
Yes.
Yes, Toprak.
Everything is good.
Great. Dr. Hala. Dr. Hala, are you there in the class? Dr. Hala, are you there? Onkar. Dr. Onkar. Dr. Gressel. Dr. Gressel, any comment? Okay, fine. That's all. No problem. Anyone else last? Voluntarily? There are a lot of people. Anyone last?
Thank you so much for everything.
Thank you, sir.
Yes, doctor. It's me.
Thank you so much. It was very, very informative as always, sir. Thank you so much.
Great, wonderful. So enjoy your Sunday and keep in touch with me. We probably meet lots of things with the hematology. I can take for 1 month, but at least I try to compile the proper literature. See, I mean, compiling all thing is a little difficult. You understand, getting all informations, put it in the MCQ in a simpler, understandable way, right? So I need to struggle a lot to just get this all things to make it simple, right? It's not a, I'm not addressing to the hematologist. I'm addressing to the physicians, right? So probably it's little different crowd, right? So I want to do it at your level, right? If somebody is a hematologist sitting in front of me, I probably go little higher, right? What's leukemia and genetics and all. That's a different story. But this is what they ask in the exam. So it's a very interesting subject, and we have a lot more things to discuss, but probably we'll do it next. So once again, thank you very much all for your precious time on the Sunday, and enjoy your Sunday and keep in touch. And you can even put your feedback in our coaching group as well. Thank you very much and enjoy your Sunday. Take care.